Whoa, that was a lot going on. That is really actually what a trauma situation often looks like. He didn't actually see that psych patient. That's really concerning. Sometimes ignorance really can be bliss, honestly, because they've been around the block. They've seen this kind of stuff. That's definitely some dark humor in the medical world. Hey guys, welcome back. I'm Jess the MD. Thank you so much for joining me. Today, we're going to be jumping into watching an episode of ER. It's been a highly requested episode. I'm super excited to watch it. So let's jump right in.
Hey, Dr. Weaver.
Leo, you're up?
Dr. Kovac gave me 15 to grab my dry clean before it closes.
We're slow, I take it?
We are now.
Gary, happy Valentine's Day.
Isn't it a little loud?
Sorry.
You know where Subricki is?
Who?
Paul Subricki. I got called down for a consult.
Yeah, I just got on, checked the board.
Thanks.
Dr. Weaver, can you talk to toxicology
What's
for me?
the problem?
Your butt booty oil? Kid drank it, but he's not symptomatic, so they won't test it. Sent it back.
No ingredient list.
Well, yeah, bare butt booty oil.
Okay, I'll talk to them.
Thanks.
Okay, so the first thing here, Dr. Weaver, she's just getting on for her shift. Seems like it's a night shift. And so all of the doctors and all of the nurses, everyone that needs something from her is trying to get her attention right away. And now she's found blood and obviously something really bad. And I'm looking forward to seeing what that is.
Surgery's on its way.
Pulse is weak.
Hell, spin a crib right away.
Get him here. Every cop in the city knows where we are.
John, can you hear me?
Airway looks clear.
John, open your eyes.
No response to command. Glasgow coma scale 7.
How long do you think they were lying there?
Long enough to lose a couple of liters.
I can't believe nobody saw anything.
Let's talk about it later.
1, 2, 3. Push your terminating sucks now.
Stab wounds to the left neck and chest. Oh man, 2 more to the belly, right and left upper quad.
Number 8, ET tube. What's your BP?
Hold on. Pulse ox is low, 82.
That's why I'm tubing her. Get me a blood pressure.
Chest tube tray.
No, start a central line.
BP is 90 over 50.
Give 4 units of Oneg, hang 2 on the rapid infuser. Give me some cricoid pressure.
You okay, Chief?
I got it.
2 stab wounds to the left flank. First one is at L2, 4 centimeters off the midline. The second one is L5 in the midscapular line.
You hit the spinal cord.
Depends on the angle.
Whoa, that was a lot going on. That is really actually what a trauma situation often looks like. I'm surprised. They actually portrayed that pretty well, pretty accurately. With the male doctor, they mentioned something about potentially hitting the spinal cord. That really depends on the angle at which the knife went in. It'll take some imaging to figure out if that knife actually hit the spinal cord, and if it did, what damage it did, if it was permanent or not.
The patient's gone.
So it was a patient that did this. Wow.
Oh boy.
What's his name?
Paul Subricki.
Who are you?
Carl Durad, Chief of Psychiatry. I was called to consult.
No one else goes in here. This is a crime scene.
Is he conscious? No, but he's responding to fluid resuscitation.
It was some psych patient. Got Lucy, too, pretty bad.
Roll him, let me see. Oh, man.
Pressure's up to 90 pal.
Why wasn't he in restraints?
I don't know.
Where's the following? That's next.
Okay, so they asked why wasn't the psych patient in restraints? Not all psychiatric patients need to be in restraints. It depends on what he was there for. Obviously, we have very little information right now, but it's not necessarily always a thing for psychiatric patients to be restrained. If he was complaining of suicidal ideation, for example, he would not necessarily be a danger to other people. He's obviously a danger to himself at that moment. Sometimes there are freak things that happen that were completely unexpected and you could not prepare for. Other times, there were things that were missed and you could have prepared for it. It's hard to say what this situation was. We have to keep watching to figure it out.
Damn it, tracheal laceration.
It's a crike.
No, she needs a trach. Get Benton in here, prep the neck, and open a Melker kit. Now, let's go. Let's
Deep
go.
tendon reflexes 2+.
Dr. Benton.
Hold on. Toes are down going. That means no spinal injury.
Kovac just mentioned toes are down going. What he did was perform a test where he basically puts a lot of pressure and scratches that doctor's foot. If the toes are down going, that means that there's normal sensory input from the spine, and that means that there's no spinal cord injury, like he said. If the toes are up going, meaning they kind of fan out, that's where you're concerned that there's a spinal cord injury. That's called Babinski's sign.
John,
Yeah?
look at me. Do you know where you are?
My back.
You were stabbed. We've got your pressure up.
Lucy.
She's alive.
Dr. Kovac.
What?
What? What is it?
Get Benson. He needs to go up now.
Get ready to batter.
Dr. Benton, we need you.
Look up Drop the thoracic.
I've got breath cells.
Benton, here. Porter's got a bad renal lag. Fully output is bite
What's
red.
the pulse ox?
Flash down to 80 again.
You got another surgery coming?
Go.
Oh my goodness. That's a lot going on right there. Okay, so John, it sounds like he has a renal laceration, meaning his kidney has been hit by this knife, and they need to get him up to the OR immediately to stop the bleeding because the kidneys get a ton of blood flow. They get all of the blood flow, and a renal laceration can be extremely dangerous and extremely deadly.
How is he?
Stab wound with renal lacerations, hypertensive. We're redlining him to the OR. Oh, a patient did this?
Yeah, they're still looking for him. Why would the guy sedated?
I don't know. Get ultrasound here.
Was he on a hold? Was there a sitter with
I don't know, Carrie. I never saw him.
What?
Kovach just said that he didn't actually see that psych patient. That's really concerning.
He failed.
Start internal compressions.
You're right. There is an effusion.
Meds.
Prep the internal panels.
Pericardium's open.
You've got a major hemorrhage here.
More suction.
Take the proximal aorta.
Keep your finger on it, Carrie.
I need a 4-proline on an RB1 needle now.
Belly's full of blood. Probably got the spleen.
Got to cross-clamp the aorta.
One thing at a time.
Auto transfuse from the cell saver.
Charge the panels to 15.
Cut!
Clear.
So they actually shocked at the appropriate time. This patient's heart rhythm was completely abnormal. She was in VFib, and that's when they shocked her. So that was awesome. It sounds like when she was stabbed, the knife hit her heart, and that's where the most concerning injury is. That is probably what has led to blood in the pericardium, meaning blood outside of the heart, but in the heart sac, otherwise known as a pericardial effusion.
How many units is that? No, it's 5, but you shouldn't be counting. It's bad, isn't it? Carter, don't worry. I'm going to explore the abdomen. I'm going to check out everything, okay? I'm glad it's you. Hey, I'm getting you through this, man.
On one hand, they say you're not supposed to doctor your colleagues, but on the other hand, especially in a trauma situation like this, someone that I know, love, and trust is exactly who I would want to be there for me in that moment. So that was a really special moment. Also, being on the medical side of things and knowing sometimes can be even scarier because you know all of the potential complications and your mind just kind of jumps to basically all of the scariest possibilities. All of that to say, sometimes ignorance really can be bliss, honestly.
Repaired a laceration to the proximal aorta.
What happened?
She tamponaded. We had to crack her.
Move it, Peter. I got this.
So they mentioned she tamponaded. What they were saying in shorthand is that she had a cardiac tamponade, meaning not only did she have that pericardial effusion, but there was so much blood that it created a tamponade, meaning there was so much pressure on the heart in that heart sac on the heart that it caused her heart to essentially stop beating or go into an extremely irregular rhythm like she was when she was in VFib.
Okay, he presented with a headache. Right, Paul Sabricki. Mark, please tell me that you saw him.
Yeah, I saw him. Lucy worked him up. Carter supervised.
And who supervised him?
The LP came back negative.
You know what? If you wanted to leave early, you could have at least rounded.
Sorry, I ran the board with Dr.
For
Kovac.
how long? For 30 seconds?
He was up to speed.
Hold on. You didn't tell me he was psychotic.
I didn't know he was psychotic. Did he present to you?
No, I didn't see him. I thought we were waiting for a psych consult.
Unless his status changes.
Yeah, but someone should tell me that. I was managing the whole board.
You were having a party.
Hold on. Carrie, we both thought that Lucy and Carter had it covered.
Well, they didn't.
Excuse me.
We both know that we use the residents to keep us informed.
Are you blaming Carter, Mark?
No, I'm not blaming anyone.
Usually in a situation where it's an upper level resident that's working up a patient, the attending may drop in, lay eyes, see them for a second, but are not going to be necessarily actively managing that patient. And so I understand Kovac saying,
yeah, I thought John had it handled.
It seems like there was not necessarily miscommunications, but there was just a little bit of the event that was not quite well communicated. Why was this patient getting a psychiatric consult when he came in for a headache? Did they maybe think that he had a functional neurologic disorder going on, especially if they did an LP, a lumbar puncture, and that was fine? It sounds like they didn't think or even know that he might have been psychotic, but they might have been consulting psych for another reason.
Excuse me, I have Samantha Sobricki with me. She's looking for her husband.
You better come with me.
I don't believe you. Where's Paul? I want to see him.
He's not here.
Paul wouldn't hurt anyone. He couldn't.
He needs help, Mrs. Sabricki.
There's been some kind of mistake.
We believe he may have schizophrenia.
Schizophrenia is a very serious mental illness, and it affects how people think, behave, how they're in touch with reality. And this patient may have not really been in touch with reality, not even realized what he was doing. He could have been hallucinating. It's really horrible when it may not even have been malicious intent that he had when he hurt these people.
Didn't have time to get a three-way or an IVP?
His crit was falling. I didn't want to chance it.
The colon is lacerated, all right. All right, 3-0 silk on a GI needle.
Dr. Anspaugh, there's blood welling in the hilum.
All right. Isolate the renal artery and get a clamp on it.
He's hypotensive, heart rate's up to 120.
All right, we got to get this kidney out of him before we lose a move.
Hold on, let me finish suturing his colon before we do something drastic.
I'll dissect out the arteries and tie them off. Come on, mix the move.
I said wait, Peter.
Why? He's lost too much blood. His hilum is trash.
Dr. Anspaugh, he's getting shocky. Pressure is 78 palp.
All right, pedicle clamp. Come on.
We still have some time.
No, we don't.
Peter, will you calm down and you listen to me? Before there's no turning back, let's check the source of the bleeding one more time.
Too many vessels are injured.
Squeeze in another unit. Let's be sure.
It seems like that older doctor, he's definitely in attending. The younger doctor, I think he might be a resident, and he's jumping to conclusions and a little bit frantic because he's extremely worried about someone who seems like a very, very close friend. The attending is being a lot more calm about things, and I definitely noticed that when I was on surgical rotations, that the attendings were always just a little bit more calm than the residents because they've been around the block. They've seen this kind of stuff and they know what to do next. It's really, really incredible. I remember being on the trauma surgery service and we had a trauma come in, and the trauma surgeon that was on at the time was also a vascular surgeon, and I was just completely amazed by how calm and collected he was in a situation that was extremely dire.
You don't know he did it.
You're right, we don't know for sure, but we still really need to find him.
He's not at the home address and nobody's seen him at the diner.
Is there any other place he might go if he needed to feel safe?
So he's a little depressed. It doesn't make him crazy.
Maybe not. But at the moment, we have to assume he could be a great danger to himself or other people.
Sometimes he goes to the roof when he wants to be alone.
The roof?
Of our apartment building.
If he really does have more significant mental health issues than she even realized, because a lot of people are really, really good at hiding that kind of stuff. My first thought is he sometimes going to the roof because he's having thoughts of harming himself and doesn't want to scare her, doesn't want to say anything to her, especially if he's having things like hallucinations because he really does have schizophrenia and those hallucinations are scaring him. There's just so much that could have been going on in his head that he wasn't sharing with anyone that really could have been much, much worse than she really thought or realized.
They need me in the OR. I'll be back, Lucy. Hold on. Her SAT's down to 82. What is it? Chest pain. Sudden onset. Put her up to 100%. We need to go for a spiral CT right now. Yes, Lucy, PE is a possibility.
What's going on?
Sudden onset, chest pain, dropped her SAT. We're going to scan her for pulmonary embolism. Bolus 5,000 heparin. Start a drip at 1,000 an hour.
Whoa, hold on. Keep going. Come here.
They said PE, a pulmonary embolism. That is a clot that forms somewhere and then ends up somewhere in the lung. Depending on where it is, it can be completely catastrophic. If it's a saddle PE, meaning blocking the entire blood flow to both lungs, that is very, very quick and sudden death.
BP's 112 over 78, pulse 102.
AC 14, tidal volume 600, 100% FiO2.
Don't worry, Ms. Knight. We put far too much time and energy into your training to lose you now.
That's definitely some dark humor in the medical world, and I think that she appreciates it. In a situation that's extremely scary, having just a little bit of humor can be helpful. I know in some cases people might think that's insensitive, but at the same time, when you're in a situation like this, day in, day out, you're dealing with scary medical things with death. Having some of that humor just makes things a little bit lighter and a little bit easier to deal with. I'm here for it.
BP's down to 60. Pulse on 72.
Lucy?
No cardiac pulse.
Damn it, she's thrown another clot. Is systoling?
Push an ampivatropine.
When was the last epi?
4 minutes ago.
Push another 7 milligrams, now! Clear!
Okay, that's it. We've done everything we can. Holding compressions.
Time of death, 2:56.
I don't have a lot of words. Awful just doesn't cover it at all. This is a colleague, a friend. They did everything they could to save her, and sometimes once a trauma situation like this happens, there's only so much you can do to prevent something like this from happening. And her body was just reacting and throwing clots, and she must have had a saddle pulmonary embolism. That's my guess as to why she coded and died so suddenly. And there's only so much that they can do in an instant to save her.
Oh, my back is killing me.
Yeah, and a hematoma around the lumbar plexus. I'll give you some morphine. I want you up and walking in 12 hours, okay?
Lucy's dead, isn't she?
He's going to need some serious therapy because survivor's guilt. There's so much to that he's going to have to unpack.
We still need a pressure transducer for trauma 1 and get 2 units of Oneg down here.
We're out of NSF.
We'll call the pharmacy. How did this happen?
We talk about it later?
Yeah, sure.
It's crazy because life goes on, you know? These crazy things happen, and it happened in one night, just a few hours, and then you have to very quickly deal with it because you've got to keep going and do the rest of your job and take care of other people while you're sitting quietly in your very, very deep grief about a major situation that just happened. In this situation, it was with someone that they knew very well. But even when it's a patient that you didn't know, if you lose a patient, especially in this crazy traumatic situation, it sticks with you, but you still have to keep going. You still have to do your job. You still have to see other patients and you take care of them. And you kind of got to stuff it down until you can be alone or be with a therapist or a counselor or someone that you love and trust to talk to about this. And then you can unpack it and deal with it. But in the moment, you have to just stiffen up that upper lip and do your job. This is a tough part about healthcare because there's a lot of traumatic stuff and you just have to shut down those feelings while you do your job and then deal with them at a different time. And it's a lot. Okay, wow, that was a heavy episode. Thank you to whoever recommended that episode because it was a really good one. If you enjoyed this episode, like down below, subscribe to the channel. It really helps the girl out. Thank you so much for joining me. I hope you guys learned something there and enjoyed watching this episode. I'm Jess the MD. I really enjoyed spending time with you. I hope you enjoyed spending time with me, and I will see you in the very next one. Bye.